We shall now go on to our next speaker, Dr. Aravind Roy, who's a Senior Consultant Cataract, Corneal and Refractive Services from LVPI Vijayawada. And he is going to tell us about appropriate usage of intrastromal antifungals. On to you, Dr. Aravind.
Thank you, Dr. Chitra, for the opportunity. Do let me know if my slides are on screen.
Yes, they are seen.
You're audible, Aravind, and slides are on screen. Thank you.
Okay. We shall be discussing another aspect of corneal surgery, the appropriate use of intrastromal antifungals. Fungal keratitis in a hot, tropical and humid climate such as ours is quite common. However, we do see a lot of variability in the clinical features, the treatment outcomes, the antifungal susceptibility. And this was what was found in some of the reviews that we performed on the subject. And we also found that this could be because of species level variation and also the geographic variation of the distribution of fungal keratitis that we see across different regions of the country. And therefore, that comes to this entity of the recalcitrant fungal keratitis. As such, fungal keratitis tends to take 6 to 8 weeks at least to resolve, and a non-resolution of 2 weeks post-therapy with antifungals has been labeled as recalcitrant fungal keratitis, and in that different surgical modalities do exist which act as adjuvants. And sometimes fungus may be sequestered into the intralamellar corneal tissue, and this is also common, such as in the setting of a post-DSEC or a post-LASIK flap. And in such cases, because there are concerns about the penetration of antifungal drugs, these drugs may not reach the deeper areas of the cornea, and thereby that allows these stromal pockets to allow the fungus to proliferate. And this was one such very interesting report published earlier by Dr. Tu and his group, where they had fungal sequestration post-DSEC 3 months, and this is the clinical picture, and the bottom is the OCT, which and also the confocal, which showed budding yeasts. So in such cases, intrastromal injections provide a depot or a bolus of the tissue at the site of where the infiltrate is, and therefore they provide a high concentration of drugs over there, which allow the drug to reach the area and allow in resolution. So these are some of the cases, but then as there is a lot of biological variability, and also there is a lot of variability from one patient to other. We definitely need to kind of customize the treatment, and there is no such thing as one size fits all. So this is one such case that we saw recently of a 56-year-old male who was a diabetic. There were raised blood sugars, and this was a 3-day history. But in spite of 2 weeks of treatment, and subsequently the culture also yielded fusarium, and the patient was being treated with natamycin 5% with atropine. There were deeper lesions with a melting and almost a 40% thinning. And this is where we decided that because in view of the deeper lesion, the melting, and also the propensity to perhaps even thin out further or perforate, we decided to plan for intrastromal injection. So this was the clinical picture as the condition continued to worsen, and as we can see that there is a subtle melt, but most of the lesions were restricted to the mid to deep stroma, and there were plaques on the corneal endothelium. And at day 21, a decision for intrastromal injections were made, and this was 1 week post intrastromal injections, and all the time the patient was on topical therapy. Subsequently, we see that there is a area of scarring which was involving the mid stroma and also the periphery of the corneal lesion, and also the peripheral scarring and blunting of the infiltrate edges were also noted. In fact, with that, we also saw that there was some amount of reduction of the plaque, and subsequently the patient completely healed, and this was 11 weeks post-injection. And vis-a-vis in a very different clinical scenario, this was a patient who was again a diabetic, was subsequently controlled, but at 1 month history, we found that this was a patient who had filamentous fungus in the scraping. The culture yielded Aspergillus species, but what we see here is a dense plaque in the central cornea, and there was a blood-tinged hypopion. And at 1 to 2 weeks, we gradually saw that not only was the hypopion increasing, but there was also a central melting. And almost at 2 weeks' time, there was a 2/3 hypopion that was filling up the chamber. So this was a case which from the looks of it, and also we know that the Aspergillus was very fulminant, and there was a lot of reaction in the chamber. We decided to plan for a therapeutic penetrating keratoplasty, and pretty soon, within 2 weeks of the surgery, there was a AC recurrence. And not only that, there was also a scleral extension, and ultimately the eye was lost. This was a failed graft. So how do we customize the treatment? So is it only because of the propensity of how fulminant the lesion is, where is it located, what kind of organisms are we dealing with? These are some of the dilemmas that the surgeon always faces. But having said that, in deeper lesions, sometimes it definitely helps to give in an adjuvant injection, and these are some of the injections that are currently in use for antifungal agents. So these include the voriconazole, amphotericin, or natamycin, which is in the sol form. The concentration that is recommended is a 50 microgram in 0.1 ml, and usually a tuberculin syringe is loaded up with the drug. The drug needs to be prepared, so this is not available per se, but it needs to be formulated and then injected accordingly. Typically, we do use the voriconazole and amphotericin B, but natamycin in its sol form has also been recommended, and even in a recent publication that was also found that natamycin in the sol form was perhaps little more effective in faster resolution, and amphotericin B in that study was found to induce more of vascularization. The mechanism is the same as for any antifungal medications, where polines cause a cell wall permeability, increase of the cell wall permeability, and azoles inhibit the ergosterol synthesis. This is the basic technique in which intrastromal drugs need to be injected. So after loading the drug in the tuberculin syringe and then using a 30 gauge or a 29 gauge needle, it is injected with the bevel down. And after that, the degree of hydration of the stroma helps us note that the drug is adequately deposited in the medstroma. Usually 5 divided doses are given, and they are all injected as a barrage around the central lesion of the cornea, all in all. And after that, this procedure, we also continue with the antifungal medications. Typically, one can repeat 2 to 3 injections, and these are given after 72 hours of the first injection. So 2 to 3 injections after the first intrastromal injections have been recommended. There are different case series which have suggested that a targeted delivery helps in a safe and effective way to treat deep recalcitrant fungal keratitis, but that has also been refuted by other studies which also show that while the treatment has been successful with intrastromal voriconazole, but topical voriconazole in addition to natamycin is equally effective. So where do we go from here? That what is coming out from the body of literature that we have at hand is that intrastromal injections are definitely an adjuvant, but one needs to customize the treatment on a case-to-case basis, and then always use clinical judgment while using any of these techniques. And at the same time, the mainstay of treatment still continues to remain the topical therapy, and the resolution is very dependent on the fungal genotype, resistance pattern, glycemic control, and the load of infection. Thank you very much for your patient hearing.
Thank you very much, Dr. Aravind. That was a wonderful talk and very detailed. I have one question. When would anybody think of combining intrastromal with an intracameral injection? And if so, would they be giving more number of injections? Or is it done?
we can do that. The intracameral infections tend to, the intracameral injections, I'm sorry, tend to kind of assist after washing out any load of infection that might be there in the anterior chamber, with again supplementing those diseased tissues with a flush of the antibiotic that remains. However, because of the clearance of the drug, which is about 6 to 8 hours, practically no drug remains in the anterior chamber. Therefore, intracameral medications have a very short half-life, and therefore they do not really add much to the effect of treating these infections. Therefore, the intrastromal, on the other hand, is more of a bolus dose, which is pretty much there in the stroma, and therefore it has a longer longevity in the tissues.
Dr. Namrata, you want to come in? You've been using.
I think Aravind has covered it very nicely, and he's covered it very completely also. And he's right. Although I have a little tendency, if I see that there is a hypopion and I'm giving intrastromal, I would also give intracameral. And but just for a hypopion, I would not give intracameral. But if I'm giving intrastromal and there is a hypopion, then I would give intracameral. But there is nothing to suggest why it is done. It's purely anecdotal. But I think he's put it very nicely. Aravind has given fantastic
Dr. Namrata,
presentation.
your
I
selection of cases. Can you tell us where would you think of giving intrastromal? Which cases? At what point you decide that, you know what, now intrastromal?
So if there's a recalcitrant fungal keratitis which has not responded to topical and systemic, by topical I mean topical combination therapy, natamycin, voriconazole, and your systemic medications for 4 weeks, then I would give intrastromal. I mean, that is what we have said in our TST protocol, which is topical, systemic, and targeted therapy. TST word was coined by Praful, who's again sitting here. But that is how we do it. But having said this, they should be given earlier than later, and very nicely shown by 2 cases of Aravind. In first case where they gave it earlier, it resolved in this. In the second case where actually it presented late and it was already going up to the limbus, there it is not going to help. You have to have a clear corneal area around the lesion, only then it helps.
Is there a role of intrastromal voriconazole for acanthamoeba keratitis?
I don't think anybody has tried. People have tried only topical voriconazole for acanthamoeba keratitis with limited role. I mean,
we
I
use
think
systemic fluconazole for those where we suspect a scleral nodule or adjacent scleral involvement. But I agree with Dr. Namrata. Not really, we have not really tried.
Himanshu, any other question? We go on to next speaker.
I think we go on